Welcome to another episode of Under the Influence podcast. I'm one of your hosts, Aunee Bhogatia. I've been known, for the way that I talk a lot about my trauma and addiction and recovery to help raise awareness, education, and help me actually to navigate my own path in recovery. So a bit about me. Pass it over to...
Yes, so I'm the co-host. Been doing this for a little while now. Love doing this, and I'm Dilesh Popat. And what I'd really love about this is introducing new guests, bringing new speakers. And I'll introduce Shannon Graham, who we've got in today. This was, I'm going to call it, it was a bit of gold that landed on my lap, I'd say. So I was talking to Dr. Joel Layla, as some people may know. And I was talking to Layla about doing a podcast. And she was like, I think I have the perfect person for you. She was like, Shannon, she's quite new. She's been at Turning Point for about 6 or 7 weeks. She'll be perfect. Her knowledge around neurodiversity, knowledge around prescribing. And she also spoke about your history of working for CAMS. Yeah. And also mentioned along the lines of working in forensic psychology.
Yeah, so I was in forensic inpatient services for quite a while.
Yeah, and that was based within women as well.
Yeah, it was generally women's, and then I had a short period of time working with adolescents that were also in the inpatient forensic service.
Oh, brilliant! So you've been around for a little while, working with lots of people, supporting people. So it'd be great to know a little bit more about you and how your career has led you to Turning Point from where you started to where you're at right now, and I'm looking forward to working with you in the future as well.
Yeah, no, absolutely. Thank you for that. And yeah, thank you to Dr. Joel. So I always knew that I wanted to help other people. I didn't know how I wanted to do that. And initially I probably didn't know whether it was going to be humans or animals. But older cousin had kind of progressed into mental health services as a nurse. And I saw the kind of joy she was getting from it. So I then started working with her. It was in CAMS in Northern Ireland as a healthcare assistant. Realised that that's what I wanted to do, so went and did my training at home. Found out that I actually really enjoyed working with people that experienced trauma, and in Northern Ireland at that point there weren't any services that worked with people, and if you consider the kind of geography of Northern Ireland and what went on, there's a lot of traumatised people in Northern Ireland. So the kind of decision was I had to move to England to be able to work with the group that I wanted to try and support. So I did. I got my first job in a female forensic unit in Northampton. Really enjoyed that work. Progressed kind of into therapy. So I trained in DBT therapy, which is really effective for people who are like high risk of hurting themselves. And kind of progressed within the kind of structures of healthcare. Spent a lot of time working with females, then had a short period of time working with adolescents in a new service, went back to females for a while, then thought I wanted a little bit of a change from inpatient services, so came up to Leicester CAMS. Really enjoyed that, but was only in their community team for about 6 months before they asked me to go to the inpatient service to go and help them out. So spent 5 years, I think it was there, did my master's in advanced clinical practice, and then really wanted a new challenge. And addictions was always something that I was very interested in, but in all honesty, I didn't have a lot of exposure or insight other than what people had told me about their experiences. But because we were caring for them in inpatient and in kind of secure inpatient settings, there wasn't the prevalence of the risk, so it came kind of lower in their needs at that moment in time. And yeah, I spent a bit of time just kind of keeping my eye out for vacancies that were coming up locally, and then saw that the Turning Point one came up, and I thought, well, I'll apply, I'll try and see how I get on. But yeah, it's been a wonderful 6 weeks so far. It's been a really kind of welcoming team. It's been a very different first 6 weeks than a lot of places that I've worked in terms of just the culture and the feel of the people that are working in the service. Has been glorious. Yeah.
Shan, can I just ask you something? You know, when forensics, I don't quite, for those of us who don't understand what that actually means, because I associate forensics with disease or something. What does it mean in the context of mental health?
In mental health forensic services, usually any secure service
Okay.
that goes beyond like an intensive care. So
Okay.
low secure, medium secure, and then high. I worked in medium secure,
Okay.
which is, apart from Rampton, the highest level of security, the females within mental health. A lot of those females haven't committed any crimes. So it's not the same as people maybe thinking like prisons and things like that. It's absolutely not. The majority of the women that I worked with, the crimes were generally committed against them. But it was the level of risk that they posed to themselves or the other people during their periods of distress that required the kind of relational security of a secure hospital environment. But it wasn't that the majority of them had ever actually been convicted of any crimes.
Oh, thank you. Thank you for educating me.
And so, by what you're saying there, it seems like you would have seen a lot, you would have witnessed a lot, and you would have seen lots of different clients or lots of different females going through different stages of life. So, is there any story or any successes that sort of take you back to that place and really think of the work that you may have done, the work that you did do, actually had a real huge impact on people's lives? No doubt you was doing that every day. But is there anything that generally stands out to you?
Yeah, there's a few, like all of the patients that I've worked with have absolutely left like lasting impressions on me, and I like to think that I'm very composed in work, and I keep that real professional approach. I'll be honest with people, I'll never lie to someone, but there's absolutely an emotional kind of impact that people's stories and progress has had. And I suppose the biggest impacts, there's a few women that have had kind of massive influences on my decisions in my career and how I work as a nurse. And it would be their level of kind of honesty in regards to their experiences, feeling so hopeless and so blaming and self-critical whenever actually it was never their responsibility to hold. Their experiences were done to them. They weren't necessarily at all their choices. And actually seeing the progression of someone, realising that this has happened and this has been my experience, and I can also change what's happening now and the future for myself. And it's nearly seeing people regain their control and their power has probably the biggest kind of punch in the chest that I can ask for, yeah.
And that sort of takes us back to what we were speaking about earlier. And we was talking about earlier regarding the aspects of trauma having such a huge impact on people's lives. Yeah. And it stays there forever. And I know we've spoke about your trauma, the trauma that you've suffered in your life, and that sort of led you into addiction. And I'm guessing it's very similar in this sort of way what you're saying, Shannon, is whereas people would use different coping strategies and different mechanisms to actually deal with their own traumas that they're suffering or that they're having to go through every single day. And it's not something that just disappears. And when we're looking at trauma as such, in your experiences, in sort of the work you've done as well, in what you'd like to do, is what support do you think is out there for people? What people can do when issues have arose, or is there enough support, or should there be more? I'm just trying to think of whereas staff or people can listen to this and sort of look at good topics or tools where they can bring it in and be like, okay, well, this is where we can, or this is what we can do differently, or ask the right questions.
I think nationally, as a blanket view, there's a lot that could be done better, easier accessed, more accessible. There is a bit of a postcode lottery in place, and quite often a lot of the services in terms of like statutory support, so from your NHS providers and things like that, they're usually only accessible once people have reached crisis point and once people have reached the end of their tether. That ability to access services for talking therapies to understand, the root of their trauma, why they're feeling these extreme emotions, why they're responding in these intense ways, isn't easily available unless you've got the means to pay privately. And a lot of private providers don't provide the level of intervention that's generally offered for those people that are taking really, really high risks with their safety because of the intensity of what they're experiencing. There are some, and there are some, locally that will do that. But yeah, it absolutely could be an awful lot better. Most areas do have some level of access to like talking therapies. But again, to try and get trauma-informed services, there is a big push on that at the minute, but I'm just not 100% sure that it's completely filtered through to all services to make it accessible. It's a tricky kind of approach to navigate for someone who's experienced that and living that. It's a lot of effort actually, and if someone's on their own trying to navigate that, it's completely understandable why it feels probably completely unreachable.
I would so agree with you. I think one of the things, like before I went down the line of my addiction being really severe, before it was like a life or death kind of thing, my mum was fighting for me to, to get the support I needed, and it was a battle.
Yeah.
But when it got to the point of like, this person's going to die if they continue, obviously, then only through that did I get access to the trauma-informed therapy that I needed. And one of the arguments I have is, why can't we embed that in local services so people don't have to go down the route of nearly killing themselves or harming themselves? So totally agree with you.
I think there's a real mismatch of funding. We say that we're trying to do all of this prevention, and preventing things for the future, but the money doesn't seem to be coming through, and it isn't cheap. These are longer term therapies. They're not 6 or 12 weekly sessions and then someone's fine. It takes a lot of time to build that trust, that rapport with whoever you're working with, and then to walk through everything and then process it, repackage it, develop alternatives. That's not a quick fix, but I don't think the funding is, if I'm being honest, I don't think the funding's being pushed in the prevention of the escalation risk, because we're not stopping the risks that have already happened to these people who have experienced the trauma. But if we could prevent the deterioration of their health and well-being, then that's still a prevention and is still going to be better for everyone really involved.
And I really like how you said it, because it takes me back to when I was working with Aunee. And when working with Aunee and when she came out with the incidents of trauma that she's had in her life and what's gone on, it's, as a worker, as a recovery worker at that stage, at turning point, it was, whoa, I don't have the skills and I don't have the abilities or the knowledge of what to do here. And it was just rehab. We need to get into rehab. We need to focus on rehab, because that's going to be the best thing. Because I don't have that ability. But I think learning from incidents of trauma, educating myself around trauma, I think now I do have a better understanding. I think there's going to be a lot of recovery workers, there's going to be ARPs, there's going to be people throughout Turning Point listening to this. And what do you think people or recovery workers or our team can do better to support people that are coming in with trauma, they're coming in with issues in life where they feel like I was, where it's like, I don't have the ability, and some people do feel like that. So is there any advice or anything you can recommend that would be really beneficial for most of us?
I think probably the biggest thing that I've noticed in the feedback that I've heard from the people that I've worked with is just that honesty and that acknowledgement. If someone has trusted you and in that moment feels safe enough to share probably one of the most difficult things that they've experienced with you, quite often we become quite defensive if we're not comfortable. Okay, thanks for that. And we've just shut down that conversation. Whereas if we can say, oh my goodness, I really appreciate you sharing that with me. I know how hard that must have been for you. And I'm also not sure what to do with this, how to help you with this. And I'm going to try and find out what I can do. That person is then being received positively for probably taking one of the biggest steps they've ever made. It may have been the first time they verbalised it to someone. It may be the first time they've acknowledged what their experience has been to anyone outside of their own head. And to not shut them down is probably the biggest thing that I would advocate for. Absolutely work within your competencies, but be honest and acknowledge, actually, that's out of my reach, and I'm going to find out who best can support you. I'm going to do my hardest, work my hardest to get you to access someone that can help you with that, and then to reach for the support. There are lots of different services, especially with trauma. a lot of them are quite specialised and bespoke, dependent on the nature of the trauma. So it is a bit of a minefield to navigate. But I suppose within, like locally within Turning Point, if people did have any of those questions or wanted a little bit of guidance for how to maybe work with someone that was experiencing something like that, I am more than happy to catch up, to, you know, go through little bits.
So we'll put your email down at the bottom so people can directly email you. You'll be busy.
Yeah, managers mightn't appreciate me divvying that out, but I think it's needed. It correlates so much.
I love what you said, because as someone who obviously has been through trauma, you feel so unseen and unheard, and the first one almost makes you think, you know, I just need to be quiet, and the other one is like, I don't know what to do, but it's like, I'm seeing you, I see you, I hear you.
Yeah, and I'm here to walk with you.
It's such, exactly. It's such a simple thing and so effective. Yeah. And I think, you know, that's what you said to me, which is why, you know, I was able to talk to you more and more.
Yeah, and we specialised as well. With the Nelson Trust, and I knew the Nelson Trust as a rehab, as they're a trauma-informed rehab. And I've always heard some amazing stuff about Nelson Trust, and they do some wonderful things. And when you went there as well, we spoke about, we've been to Nelson Trust, checked it out since there. Was there anything that you did that stood out to you that was like, wow, this made me realise that life, this is what it's been, this is where life can change?
I think the thing for me was, because obviously rehab is very structured, and it's almost like, you know, they have groups Monday to Friday, but the thing that really got me from a point of the addict mindset, the destructive mindset, to actually, what have I become? I want to change my life, is the individual assignments. So aside from the group work, we were given assignments that were individual to us, you know, and that is where I really connected to Aunee. Yeah. I never knew who Aunee was. I'd spent a long time being a chameleon in trying to fit in. I never fit in because I never knew who I was. And it was through doing those assignments. One sentence, you know, and I would go off and write a 10-page assignment because I really had to connect to myself. And it was like, oh gosh, hello, Aunee, nice to meet you, you know? And it was the moment I stopped being in this inner battle and I embraced all of me, which is what led to the Aunee that I came out as on the other side.
It's nearly giving yourself that space to get to know yourself, where you maybe do kind of avoid, shut down, we just go through the motions, but actually taking that space just to think, who am I, what do I want, where am I at this moment, where do I want to get to? Sounds really powerful.
And I find more questions come up, and then it would be like, Kelly's fine, answer that question, but everything's within, right? Yeah. Because now I'm getting comfortable with being Aunee, you know? Yeah. It's exciting now getting to know who I am.
Absolutely.
And there's the things that, like, looks at tools of something like just writing. And we spoke about having tools, and the idea if we can have people walk away from today's podcast and just be like, here's a tool, or here's a golden nugget. And if there's some recovery workers, anybody listening, what golden nuggets or what tools do you think can help people if they're going home and they're alone? Because we talk about this from earlier today, where by the time you refer yourself into service, by the time you get support, by the time you see somebody, by the time it can take a long time. And ideally, if we can get people with tools and a toolkit or something they can just use when they go home, what recommendations would you have for that?
I think probably one of the bottom lines is try to show kindness to yourself. That is the bottom line. And if that's for 30 seconds and you don't usually do that and you achieve that, that is a massive success and achievement for the day. I suppose whenever we're thinking about trauma, and it also overlaps a lot into addictions, it's that kind of thread of balancing acceptance and change. Yeah. I can accept, and we have to accept, the things that have happened and our journeys to this point, and we can also then want things to be different for the future. I can accept that this has happened to me. I can accept that I'm using substances, I'm self-harming, whatever it is. I can accept that that's the choice I'm making right now, and I'm also committing to make a different choice. And again, if that's, for 3 minutes, to not have a longer gap between substance use, or if that's holding off the act of self-harm for 3 minutes rather than acting it impulsively, that is one change happening, and that small change can help and be a bit of a catalyst for more. I do think the acceptance and change kind of dialectic is really, really powerful to an individual, because quite often you feel like you don't have options and you try to avoid what's happening. And actually change can come if we do that. We have to accept our journeys and our experiences and then think about what we'd like to change and also how we can change. We can't keep doing the same thing over and over again, expecting a different outcome. But those changes can be as small as they need to be, and they're still positive steps.
That's powerful. Yeah.
I think it's quite a nice balance of it, because you can apply it to so many different areas. People who maybe wouldn't view themselves as experiencing trauma or having difficulties will still absolutely have life stressors and everything else. And that sort of view can actually help with day-to-day stress. If we accept what's happening, and then if we can change it, how are we going to change it?
And I love the whole even 3 minute thing. It can be as small as 30 seconds. It's a change, isn't it?
Yeah.
And that's in any field as well. That's like when we look at the addiction. If you have a craving or a trigger, you avoid it for a few minutes, and then that craving and trigger may go again. It's just that change of thought, and that's the idea of we can support people to just change their mindset, change their thought for 3 minutes. It might save their life, and that's the power of just little tools that we can give to people. And that's what this is about, right? It's about
Absolutely
how we can support and how we can give tools to people, and that's the idea of the aspect of overall of trauma and stuff that you've been working around for many years. And it's great to see that there are so many tools, and we always sort of, when we talk about trauma, you need to see a therapist, you need to see a counsellor, you need to go to the GP, there's so many you need to do, and people feel that they haven't got the tools. Yeah. And this is what we can do, is build tools together and sort of just some little nuggets. And we were talking about it earlier about being able to do just what you're grateful for, a list of things that you're grateful for, and that sort of allows people just to change their thought pattern from where they're at to where they want to be. And even something so simple as the sun is shining. I'm grateful for that, and I'm absolutely grateful for that. And I know you come here and you spoke about your animals. You spoke about your dogs and spoke about how passionate you are with animals. You wanted to go into animals before you got into Turning Point, or before you got into this line of field. And there are other things that people can use as well as tools. It's not just themselves. So do you feel like within your lifestyle and I know we'll talk a little bit more about that shortly, do you feel like you've had a lot of positive aspects from other people in your lifestyle, including your animals, and to allow you to grow? Because you've spoke a little bit about ADHD to me earlier. We'll touch upon that. We'll touch lot to touch upon. But do you feel within your lifestyle you've had lots of different tools and lots of different coping mechanisms just to cope with your life and things that you see and what you witness? Because that's trauma as well.
Yeah, I would say I have. Like, I grew up in a very supportive and stable family, absolutely with our own quirks. We're from Belfast. We're very lively. Absolutely had our own quirks. I grew up at kind of the tail end of the Troubles as well in Northern Ireland. So there was exposure to a lot of pain, a lot of trauma. I was kept very sheltered from that, by my parents. If we were going to a police checkpoint because they were checking cars for ammunition, or if someone, was there that shouldn't, and we asked my parents what was happening, they just said, oh no, they're just checking that everyone's got their seatbelt on. We were completely protected. I didn't know the Troubles was happening until I was a teenager, and it had already ended. So I think from that sense, absolutely, I was given the kind of culture of Northern Ireland. There's a lot of dark humour. We see the funny side to things that possibly others might gasp in horror at. But that's how we coped with that level of trauma that we were kind of living with day in, day out. But then I completely moved away at 21 on my own to Northampton, where I didn't know anyone, came to a place where I knew no one to start my first job. And I think the resilience, I suppose, in some ways that had unknowingly been kind of drilled into me. I look for the positives in things naturally. My mum's a very positive, optimistic person. My dad is as well. You know, he's very much finds beauty in most things, you know, and will comment about the things that bring him joy and is very acknowledging of that. And I think that early exposure to that then helped me in those times where I did feel really lonely. I felt really isolated. You know, I was this weird person from Northern Ireland living with all of these people that knew each other for a lot longer. It helped me kind of then look for the things that I enjoyed, and it was animals. You know, I always grew up with animals. So as soon as I moved out of staff accommodation, dog was first on the list. But also being able to reach out to other people when I felt maybe that I was sitting in my own thoughts a little bit too much and maybe feeling lonely. And that could have been ringing my mum, or it could have been texting someone that I worked with saying, you know, what are you up to? You should have to go for a coffee. I mightn't have shared with them why I was reaching out to them, but actually doing something to change how I was feeling absolutely then helped me not feel horrific for any longer than I already was.
I love that, because I think one of the things that before I got the trauma-informed therapy was the fact that I didn't feel I had choices.
Yeah.
And going through the therapy and connecting to myself, I realised that I felt empowered, should I say, empowered to make choices. And you just reiterated you know, although you went through all that trauma, that resilience and that knowledge that you had choices, you know, and you made a choice to come here.
Yeah.
You know, at a very young age. You know, I've got a daughter who's going to be 21, and she's like, it might as well be 16. You know, not because she's immature, but because
21-year-old.
But I love that, and I think that's the very essence of, you know, going through trauma, coming out the other side feeling empowered to make choices and trusting yourself in the choices that you make.
And I think being able to share that, which you do very eloquently, and like I cannot compare my like bystander awareness of trauma and experiences to someone's true lived experience, but I can absolutely share with them how even imagining that might feel. And I think sometimes as professionals, we feel like we can't say, oh my goodness, that is horrific. Like, I actually can't believe how you survived that. Like, how incredible that you're still here sitting in front of me. And quite often professionals feel like, oh no, you can't say that. Why? You know, that is probably the greatest validation of someone's experience that you can give them. I can't imagine, you know, some of the experiences some people I've worked with have gone through, but I can imagine that I wouldn't be able to cope as well as they are, and to be able to sit in front of me and string a sentence together. And I think sometimes being honest human rather than a professional robot can actually speak a lot more than following, you know, protocol. Yes, protocols are there for a reason, but I think you have to be human with the delivery of it. You know, we're working with humans. We are humans. We all have problems. We all have families, everything else. And I don't think there's anything wrong with acknowledging. Like, that is just unbelievable, and I can't believe. It's just, again, it helps people feel heard, and also you're actually validating that what happened was a lot.
Yeah.
There's a couple of words I took out of there, and he said robot and humans. And that sort of made me sort of think about your other specialities or the knowledge skill set that Layla mentioned to me.
Mm-hmm.
So Layla mentioned neurodiversity, ADHD.
And autism. Spent a lot of time.
Autism, and they were the two things. And I think at the moment, neurodiversity, autism, ADHD, like, they're everywhere. You hear in the social media, you hear this is how you treat with ADHD. This is what neurodiversity is. There's a lot. We're learning a lot now about it. It's coming more to the forefront of us in our eyes. I'm sure we're sitting here. I think Aunee said to me at one stage, I think I have ADHD, and I'm sure I've said, so I think I might have ADHD too. And no doubt, I think you mentioned at the start your own experience ADHD. So we're all like, and I think, like, for us, we're hearing it and seeing it now all the time. And you, for yourself in the clinical side and working with people, do you see the link between neurodiversity and trauma coincide with each other?
I wouldn't say that there's like a correlation necessarily, because people can absolutely experience trauma and not have neurodiversity, and people can have be neurodivergent and not experience trauma. But what I would say is quite often there's diagnostic overshadowing, would be the term that would be used, where whichever is kind of more prevalent at that one time in that one appointment for that 60 minutes with that one clinician that probably specialises in one or the other, that's the one that'll be addressed. And sometimes there's not the awareness that they can absolutely cohabit with someone and that is someone's genuine experience. I suppose from the information, the research that's available, especially with ADHD, there is an clear prevalence of more people that are in kind of substance use services present with diagnosable presentations of ADHD in comparison to the rest of the population. So the general population's kind of 4 to 5%, and that's probably still underdiagnosed if you compare it to other places around the world. That's just like the UK. Within substance use services, the evidence and the research shows that that's anywhere between 25 to 35% of the people presenting in substance use services could potentially be diagnosed with ADHD. And I suppose some of it's about saying, well, why? Is there the self-medication aspect of it? Is there the impulsivity, the impacts on dopamine and the reward center and things like that? There's a lot of potentials as to why that might be the case, but I don't think anyone's actually drilled down yet. And as far as I'm aware, there's no real overlap between ND's neurodiversity kind of services and addiction services. If someone presented a turning point and we felt that they may be neurodivergent, we're not going to assess that formally. They would be referred to the appropriate local service for that. And you do wonder then, how long does someone have to wait? Can they stay engaged? Are they going to engage with a new person? There's a lot of room for more kind of enmeshment of services, I think, and like co-working between services.
Can I just ask, sort of just leading on that topic, when I was in active addiction, and I was seeing psychiatrists and things, I was given a sort of preliminary diagnosis of borderline personality disorder with symptoms of psychosis, etc. And as I went through the trauma-informed rehab and came out the other side, it turns out I don't have borderline personality disorder. It was just that I'd had so much, trauma upon trauma upon trauma that I'd never actually processed. And that was actually the symptoms that were coming across. But since being in recovery, I've spoken to so many women and heard so many women speak about that misdiagnosis. And from my own perspective, it seems like a very common thing, just talking women here, where they're commonly given a misdiagnosis of borderline personality disorder when actually it's a lot of unresolved trauma. But just wanted to gain your clinical perspective on that, actually.
I would agree with your experience. And again, it's from what I've seen and in my own practice and also what's available in the evidence base. The vast majority of women diagnosed with borderline personality disorder, emotionally unstable personality disorder, whatever anyone's preference is for labelling it, the majority of those women have all experienced some level of trauma, and it's usually in early childhood. Both those diagnoses, the BPD and the EUPD, predominantly sit with females. That's fact. And absolutely the treatment for EUPD, BPD focuses on acceptance generally of trauma and then change of behaviours, choices, whatever that might be. So I would completely agree, and the evidence completely agrees that there is that prevalence, that it's generally there. There's a small percentage of people with a BPD diagnosis that there's no documented trauma. That may be because it hasn't been disclosed. That may be because of something else. But I suppose the other thing is the label. I think, telling someone their personality is disordered.
Well, I'm going to tell you how it was for me. When I read it, I was like, what on earth? Like, I really am, like, messed up, already felt messed up. And it was like, it was the emotional instability, it was psychosis. I was thinking, oh, I'm crazy. I'm officially crazy, and you're already in a dark place You're already paranoid, and then
And if you start Googling, you know, BPD, EUPD, what you'll see is, you know, oh, it's really difficult to treat. Oh, you know, these people are this, these people are that. The treatment's really, really effective. It's just accessing the treatment's really hard. And that's the bottom line. You know, the treatment is really, really effective. Trauma-informed kind of psychotherapy, counselling, dialectical behavioural therapy, they're really, really effective in treating those presentations and those experiences, but it's accessing them's the difficulty. That's where the kind of barrier sits and the problems seem to sit for people.
Interesting. That made me think, why do you think it's more so women than that are diagnosed with that? Or
I suppose my views in some ways of that is probably why women are offered less pain relief and less often and less quickly than their male counterparts would be. You know, if we think of even like gynecological procedures for women, very little pain relief's offered as routine. There's obviously a big push for change now. I wonder if it's along the kind of similar routes that it's just easier to give someone a label, suggest to give them some antipsychotics, which tends to be, you know, the go-to. They're not psychotic because they can't access the treatment that's needed, and it creates, I suppose, movement in services where they can say, oh yeah, we've diagnosed them with that, this is what we're offering, there's nothing more we can do, case closed. Yeah, would probably be my view of it. And from the experience of the women that I've worked with, that tends to be
the case.
Some of their experiences.
Interesting that we talk about the difference of women and what I say male. I think we was just touch upon neurodiverse ADHD as well, and talk about drugs and certain drugs regarding ADHD. We know our treatment service is mainly populated by men. And I think one of the things that we see, and you said earlier, I just want to move it back to that slight conversation. You mentioned about certain drug people you have neurodiversity or ADHD will come into drug treatment services. A large proportion. That was a big wow factor for me. I was like, wow, that was the first thought. I'm trying to not say it out too loud. But the wow factor is, do you think there's, when we look at the services, because do you think there's certain drugs that people with certain neurodiversities may lead to? I know crack cocaine and cocaine seems to be a lot of people that self-medicate, I hear. I know that a lot of people would self-medicate using cocaine and crack cocaine. Is that something that you've come across? Is there any evidence based around that? Or is that sort of just what people are saying? It's just because I have ADHD, this is what I'm using? Or is that...
Yeah, no, with the move into Turning Point, because substance use is very new to me, I looked at a lot of research around trauma and substance use and also neurodiversity and substance use because they're very comfortable for me. I thought, well, let's introduce the substance use in through the areas that are comfortable to me. And from what I've read, it generally does seem to be kind of cocaine, amphetamines, and cannabis seem to be the kind of preferred and what's detailed in kind of the research papers around the prevalence of it. And I suppose whenever we understand how some of those drugs work and also the prescribed medications that's used for ADHD, you know, they are stimulant medications, and they have almost the opposite effect on people with ADHD than people who don't have ADHD. It kind of opens up all the pathways so that maybe we're not as impulsive, as distracted, but in someone who didn't have ADHD, people would then feel very stimulated with it, but someone with ADHD doesn't feel the stimulation benefits of it. It's more just within their cognitions that, you know, all the pathways open up. And then cannabis, I suppose my views were around the kind of relaxing elements of, you know, if someone's mind's on overdrive, thinking of a million things at once, struggling to get anything done because they're trying to do 10 things at a time, you can see why cannabis may be the other drug of choice, to maybe slow things down a little bit and to take things at a more steady and achievable pace.
Interesting. And it makes sense now. So I don't know, it's Dave we speak to in the office who has ADHD. and his past use was crack cocaine, and he'd always say he'd be calm. Yeah, he'd use crack and he'd be calm and everything be fine. And I even know when I was going out as well with some of my friends, and some of them you'd literally see the ones that was quite just shut down, and they'll be there relaxing and sitting down and enjoying the time, where others got somebody in a headlock telling them the life story, where you can see that interest in is how that connection you see.
No, absolutely. And like if I think about my own experience, like I'm diagnosed with ADHD, and whenever I started on methylphenidate, which is a stimulant medication that's used to treat it, you start off in a very low dose, and you're titrated very slowly up just to check that you don't have any of the undesired effects, that I'm not running at 500 miles an hour and my heart's not doing the same. I could not get over the quietness that happened in my brain. About half an hour, 40 minutes after taking my first dose, I sat on my sofa and I was like, there's nothing running through my head. I've got no songs playing. I'm not thinking about what I did yesterday. I'm not thinking about what I have to do tomorrow. I'm not talking to my dog in my head. It was the first time in my head that I had ever experienced just silence. And I thought that was normal, that everyone just constantly had, some random song playing in their mind, or some random jingle they'd heard on an advert, walking down the street, bus noises, hearing that being replayed. Just to have that silence was crazy. So again, if someone's undiagnosed, unaware, and is potentially getting that effect, again, you can see how the addiction can start, because actually it is self-medicating. But I suppose it's so important to identify the risks that come with that self-medication, and actually the availability of safe and effective treatment that can absolutely give that result at the end that's safe, monitored, and prescribed individually for them.
Can I ask you a question? Because I always have things going through my head all the time, so I couldn't actually imagine it being silent.
Crazy.
But have you found that beneficial over time, or is it like, actually sometimes I miss things going through my head and I need that mindset, and sometimes, because I couldn't imagine it being silent.
I really appreciate it in work.
Okay.
So I really appreciate it in work. I'm on a longer acting medication, so get anywhere between kind of 10 and 12 hours. So I try to take my meds at about 6:30, 7, so that they're out of my system by the time I get home, so I can be back to being kind of Shannon that I've known for all these years whenever I'm at home. I have found kind of weekends, I feel a little bit dull sometimes. But I'm also kind of adjusting to it. Okay. And initially, I would say I was really, really dulled by it. Whereas now I think I have a little bit more awareness. I'm more consciously making decisions about what I want to do, what I want to say, rather than it being completely impulsive. I will still say the fruity and shocking things that I used to say, but I'm consciously making a decision about it now, rather than it just coming out and then going, oh, I'm sorry.
And I've got to let you see, whenever we do these podcasts, I say things I might get sacked on. So I've got to make a confession
here.
So
it's nice knowing you.
Yeah, so it was a pleasure. It was short but sweet. But my friend he's medicated for ADHD, and he always says, "You definitely have it. You do." And I'm like, "Oh, whatever." He's like, "Take one of the tablets one day and take half," and which I took half a tablet one day, and it was just because
we do not advise.
I know you don't. This is why I said I'm very close to getting sacked. And he said, "Take half." And one thing I realised is, within an hour or so, my focus on the computer when it was doing, there was no noise, there was nothing, I was driven. I got so much done within an hour, and it was great. And I was like so focused and so driven. I was like, wow. I need to go and see somebody. But then what happened later on is I went to a meeting to go and meet the Spinney Hill Recovery. Mm-hmm. And normally when I'm there, I'll be talking to them, and I've got my brains, we'll be talking about things that are going on. I've got all these ideas. I'm like, why don't we try this? Why don't we do this? Why don't we go there? Why don't we do this? I got there and I just felt like nothing. I had no ideas. It was just like, I just felt, for me, it was like I like this personality. Mm-hmm. I like them thoughts. I like and this is that sort of direction we're going for.
It was off the back of that experience.
It was off the back of experience. Oh, was it? So you saved my job. So no, but it is, and I think when we look at clients that we're working with within Turning Point, people that we know, we generally all know people that are suffering with neurodiversity or ADHD. Is how can we be a better service, or how can we support people better?
I think again, it's maybe the awareness, because I grew up in a family where my brother was diagnosed with ADHD very young. So I'm the older sister, he's 6 years younger than me. And he very much presented in the very stereotypical boyish way of, very busy, couldn't sit still, struggled with his concentration. And that was very, very prevalent. As a female, I think a lot of us are kind of brought up to be pleasant, polite, say your pleases, say your thank yous, look at someone when you're talking to them, wave goodbye. All of that's drilled in. The same standard of expectation, I wouldn't say from my family was necessarily there. Boys will be boys is the favourite saying. So I was working really, really hard to do the things that I needed to do because I wanted to please. And I suppose where I'm going to with that, very long-winded, is some people, their experiences, especially whenever we maybe meet them for the first time as an adult, this is all they've ever known. They may not know that there is an alternative way to think and to experience things. And I suppose, again, a bit like trauma, it's having the really open and honest conversations with you, saying, is there anything else you think might be helpful? Can you tell me a little bit about some of the things you maybe struggle a bit more with, and we can see if there's anything we can do to help. And actually, if some of those symptoms come up, there is a massive overlap with some trauma, especially like early childhood and like adverse child experiences and neurodiversity. Sometimes trauma can look like autism, sometimes trauma can look like ADHD, and with that absolutely has to be assessed formally, by specialists in those fields. But I think it's really helpful just to reflect some of that with an individual and ask them what their challenges are. If someone's really happy with how they are, we can have all the suspicions in the world, but if it's not impacting on them, they're living their best life safely, no point, me offering my judgment to someone if it's not impacting anything. But if someone's coming saying, look, I've really struggled with this, from I was at primary school, these were issues, it is maybe saying, well, actually, some of the things you've said make me just think of something maybe like ADHD. Has that ever crossed your mind? Is that something that you'd like to consider? And then in England, it's quite simple to go through the process. There is a bit of a wait, but the right to choose services for neurodiversity assessments are wonderful. So people literally need to go to their GPs with the pre-assessment questionnaires and can pick a service, that'll work for them. But again, it's being led by the person that you're working with. Just because you think someone's maybe a little bit busy, don't say, I think you've ADHD, you need to get that looked at. But, be led by them.
Yeah. And I like the fact that it's, some people may like that style of the way they are. Mm-hmm. It's not something that is if you're having difficulties with yourself, it's like if you're struggling with, and I think that's where the difference is. Whereas I know my brain can go completely wild,
and it works for you.
At shop when I'm going, I love cooking. Mm-hmm. When it comes to cooking, my brain is at I'll add this, I'll add that. Got some then I cook and I do some amazing food. And it's great, and I love that experience. But if I was to go shopping without a shopping list, it's going to be a wild experience. Yeah. If I don't have a list at work, if I've not got a to-do list of things that need to be done, I'm going to forget it. Just like I forgot to email you the time and the dates and everything I needed to email you. If I don't have certain things in certain order, I know it makes life difficult in certain ways, but I think you can also manage and self-treat it in certain ways by having structure and order and certain things and using it as a tool where possible.
I think I've learned to understand my ADHD to make it work for me.
Yeah, absolutely. And there's non-pharmacological treatment. People will use CBT and things like that for ADHD, and it is really, really effective. But I also think if people can use their ADHD, their autism, whatever, to their advantage, and it's a positive impact and it's not negatively impacting on them, why change? Yeah. Why change at all if there's no kind of negative impact? Like I know in the criminal justice system, there's a high proportion of people in the prison systems, again, a bit like substance misuse, that are very much presenting with symptoms that could be diagnosed as ADHD, and it's a much greater population than in the general public. You know, if crime's being impacted and things like that, actually, it can be life-changing for people. If they can change that level of impulsivity, and maybe other things haven't worked to this point, you know, sometimes if it is ADHD, it can be life-changing for people.
And that's it, that thing, it can be life-changing. I love that, it can be life-changing. I think that's a perfect way to sort of end on. It can be life-changing. I think we could have spoke for another 2 hours.
Oh, I could have as well.
Gladly.
And learn
I
more.
really enjoyed it.
Yeah, and I think it just leaves me to the last question. And I did tell you at the beginning there's going to be a special question, and I wanted to make you nervous right at the beginning. There's questions that we've always asked. As the podcast is called Under the Influence, we'd like to know what you're currently under the influence of, and what are you under the influence of now?
That is a very philosophical question.
It is.
Definitely heat, first of all. I'm just noticing where I'm at in my body. Happiness, I would say. I felt a lot more comfortable during this than I was expecting to. And I do think it's down to both of you. Under a little bit of influence of pride, that I made it the whole way through and didn't run off.
We'll have to do a dance.
Yeah, and yeah, that's probably where I'm at.
Yeah,
I love that.
Yeah, thank you very much. It's been a pleasure. Thank you, Layla, for helping us out, and we look forward to seeing you in the future now, because we've introduced you to Turning Point.
Yep, definitely.
Lovely to meet you, Shannon.
It was
Thank you
lovely
so
to
much.
meet you. Hopefully get to do this again.
Absolutely.
Round two.